Thank you very much. It's a pleasure to be here today and be able to share with you a physiotherapy perspective on some of the things that you may be facing following or during your prostate cancer treatment. So what I'd just like to do is just kind of set the scene a little bit. So in terms of prostate cancer and prostate cancer treatment, on the upside in this era of early detection, that means we have many more lives saved, which is a real positive. However, on the downside, we may be having, many more life-saving techniques. There is significant consequences and impact on quality of life, and that's sort of a little bit along the lines of what I'd like to focus on today. Globally, research suggests that there are many unmet needs, and these are associated with the consequences of prostate cancer treatment. And I wonder if this is also the case in New Zealand. So the question I would have is, can physiotherapy help to change some of this? And are there things that physiotherapists can do to help facilitate optimal outcomes as part of a multidisciplinary team? If we look internationally, the role of physiotherapy is exploding, and exponentially we are changing what we are doing. We are looking at evidence-based practices that physiotherapists can start to implement to try and change what's going on. And physiotherapists are really interested in men's health because part of what physiotherapy does is look at rehabilitation. Now, the two main consequences that we're looking at post-prostatectomy and post some of the other cancer treatments for men are incontinence and erectile dysfunction. And these really are quality of life issues, not only for the men receiving the treatment, but also their partners and their families as well. So physiotherapy, it's a physical medicine, and it's also a rehabilitation specialty. And within physiotherapy, there are small groups of special interest groups, and one of them has been changed just recently, actually, from women's health and continence to encompass men as well, as we sort of start to reach out into the men's world and try and involve them in what we're doing as well. And so that new group is called Women's and Men's Pelvic Health. And actually the physiotherapists in New Zealand are the first ones in the world to change from continence to pelvic health. So we are kind of leading the way. In terms of urinary incontinence, the rates vary widely within the literature. Anything up to 87% of men will be suffering post-prostatectomy urinary incontinence 1 month after surgery. Depending on where you look in the literature as to what you see the rates will be, so there really is no agreement at the moment. But what we do see is that generally by 1 year down the track, most men have recovered continence. It doesn't mean it's any less distressing for that entire year and for those that then go on to have ongoing incontinence. In terms of pelvic floor and the pelvic floor involvement, following prostatectomy, the pelvic floor is relied upon for bladder control. And what we know and what we've done so far is we've adapted best practice for men from what we know from women. Okay, and this is because we are so many years behind, unfortunately, with men's research and in terms of what to do with pelvic floor. So we've just kind of taken what we've known and run with it. So what I'd like to do is, so there's a little bit of a theme of everybody standing up this afternoon, so I'd just like you all to stand up again. And then there's a couple of things that I'm going to say that may strike fear into some of the hearts in this room. Firstly, if you don't have a penis, please sit down. So that means most of the women can sit down, okay? Now, what I'd like to do is ask you to shorten your penis. You heard me right? I'd like you to think about shortening your penis, okay? So I want you to concentrate down around your pubic bone at the front. I can't move too far away from this mic, but down here, okay? And I want you to think about what it would feel like if you were going to shorten your penis. Now, I don't have one, obviously. Promise I don't. So it is a concept that we're having to start learning about, all right? So I'd like you to shorten your penis and hold and let go and try again. Good. And relax. Okay. Did anybody find that difficult? I did. I don't have one. Okay. So there are a few hands up in the room. Okay. Did anybody find that they sucked in their stomach? Yep. Did anybody pull up through their back passage? Yep. Did anybody squeeze their buttocks together? Yep. And did anybody hold their breath? And who even thought about breathing? Okay, do take a seat. The key here is that pelvic floor is changing. We do have some research coming out, and this is a new cue, all right? And what I mean by a new cue is that we teach men like we've been teaching women, as I said before, but it's changing, all right? So this is from 2016. Now, the shortening of the penis is about trying to activate the striated urethral sphincter, which is here. This big arrow here, this is pulling up through your back passage, okay? This little arrow here is about activating the mechanism that you need to use to keep you dry, okay? Another term that's often used is nuts to guts. Anybody heard that one? Okay. And the reason we use terminology like that is because men don't want us to muck around. They just want to know what they need to do, and most men know what that means, all right? When you do nuts to guts, it's lifting up through here, which is using that urethral sphincter again and another muscle group, so it will reinforce it. But basically it means that a lot of what we're doing is changing. We have to start more subtle, and it's why it can be really, really difficult for men to understand what to do. And clinically, when I see men and we start talking pelvic floor, most of them look at me like I'm a Martian. All right, they don't really have a concept of it, and most men have never really had to think about it, but after prostate cancer surgery, in particular radical prostatectomy, you do, because it becomes what you are reliant on to stay dry. Now, am I right in thinking that given the opportunity that most men would like to be dry sooner? Because I think I probably am. So this is the concept of prehabilitation, and prehabilitation is rehabilitation before the event that's requiring rehabilitation, okay? So a little bit like what you would do before you have a knee reconstruction. You would often do some exercises and get nice and strong, and it's to facilitate your optimal outcomes. And when it comes to cancer treatment, in particular the radical prostatectomy, it affords men the opportunity to master the techniques, to build strength and confidence, and actually to take some control over their recovery. Very importantly, what you need to understand about muscles and muscle strengthening is that it takes 6 to 12 weeks to see any changes in muscle strength, okay, and 15 to 20 weeks for a training program to occur. So what that means is it takes time, and the sooner you start, the sooner you're going to see results. And so what's tending to happen internationally is that although there's a lot of research around this that doesn't necessarily support doing exercises beforehand, it's because in a lot of cases the research trials are not comparing apples and apples. They're all very, very different. But basic science is that it takes time to build muscles. So if you start before your surgery, you're that much further on. Okay, and the idea being you're going to be drier sooner. For those of you that are further down the track, probably what is important to know is that if you stop using your pelvic floor muscles and you stop maintaining that effect that you've gained, then you can go backwards and start leaking again. And so it's a little bit like any activity. It is use it or lose it. So once you get to a level where you're training, and it would be like if you went to the gym and stopped exercising, you lose your muscle bulk. So you do have to keep maintaining it. And that may be as little as a little bit every day, or a little bit 2 or 3 times a week, or even just using those muscles functionally. So when it comes to muscle strengthening, there really is no one size fits all, which is a little bit of where physiotherapy fits in, because physiotherapy are about looking at muscle function and then looking at adapting it to suit the individual. The other sorts of things that a pelvic health physio may address may be things like bladder training or bladder retraining, looking at the timing of when you're contracting your pelvic floor to make sure that you stay dry as you change position. It might be about checking that you're not doing any of those things that we talked about before that are actually activation strategies that are wrong, like squeezing your bottom or pulling up through your back passage or holding your breath. We know that pelvic floor doesn't work on its own. Pelvic floor works with a breathing mechanism, and so if you don't tie it in, that can be one reason why you're still leaking. So it is important to assess each individual person to work out what's going on. The other thing is there are a percentage of men that go the other way and have an overactive pelvic floor, and those are the men that will tend to end up with things like pelvic pain. And so it's really important to make sure that we actually go the reverse and down train those men. Physio also looks at bowel management and also general fitness, because we know research-wise that the evidence is pointing in the direction of recovery from any form of cancer is much better if you are fit and well. And there's a couple of programs, I'm sure you've heard of Steel Pilates, which is physios that are a special interest, a little bit like the pelvic health physios, that are looking at cancer rehab. The other thing that physio will look at is what kind of leakage you've got and decide what we need to do for you. And this is where physio really comes into its own, and the one-size-does-not-fit-all approach. And there really is no recipe. So that's an individual assessment. Now, as Graham said before, I was fortunate enough last year to have a study grant and went to Sydney to learn a little bit about what's going on in Australia. And it was a really interesting time to see that physios are really involved in prostatectomy care or post-prostatectomy and men's health in general in Australia. And so I really did wonder what the role of physiotherapy was here in New Zealand. And so I did a little bit of a research survey where it's not published yet. I've had a little bit of an elbow to get it published, but it's about looking at what's happening here in New Zealand to see whereabouts we're at. And what it was a research survey with my colleagues in the pelvic health arena. And what we found is that, fantastically, of the primary referrals to physiotherapy, this is the post-prostatectomy referrals, 52% are coming from the urologists, which is fantastic. But there is 25% of people that are coming and finding us themselves. And I know that we're a small group, but most hospitals within New Zealand do have a service that they can provide. And so it makes me wonder whether this represents unmet needs, where men are not getting the answers that they need and they're seeking out help. The other 23% are GPs, urology nurses, nurse practice specialists, palliative care, cancer society, and support groups. So I've just lumped them together. The other statistics that we pulled out is that at the moment only 21% are coming before surgery and taking advantage of that prehabilitation. And that of those that are being referred, 21% routinely, but mostly we're only seeing patients if there's a problem or there's deemed to be a problem by another medical professional. So moving on to erectile function, physiotherapy, this is a newish area to a lot of pelvic health physios, particularly here in New Zealand, but there's been research around for several years dating back to the early 2000s about what we can be doing for erectile dysfunction, because the pelvic floor has a role to play with erectile dysfunction. With prostate cancer, it's a little different because of the surgical techniques, and although these techniques have obviously got better and better, we're still seeing that these techniques have an impact on the nerve function, and that basically men would normally have a erection ranging from 3 to 8 every night, and following cancer treatment or following any damage to the nerve, which could be radiation or prostatectomy or anything else that has any impact in the area, the nerves go through a process where they almost go to sleep. And so while they're recovering, those nighttime health erections that just occur without you having to do anything, that's spontaneous, they don't happen. So then you lose anything from 1,000 to almost 3,000 health erections a year. And so what that means is that the flaccidity that occurs around that process allows a decreased blood flow, which then allows deposition of fibrous tissue, which is kind of like a scar tissue. So now you can see why that might be a problem. Because while those nerves are recovering, if it takes you 2 years for those nerves to recover, there are certain changes that will occur in the penile tissue, and those include length and girth changes. There is muscle architecture changes, so the whole muscle itself changes, and also that fibrosis and thickening. So one of the things that came up while I was in Australia was the concept of penile rehabilitation, which I'd never heard in my life. And it was a really interesting discussion about where to from here. Now, not long after that, I had a patient come in and sit down and ask me some questions that I couldn't answer. So it has set me on a little bit of a journey of trying to understand what the options are. And physiotherapy is about rehabilitation. That's kind of what we do. We have a role within many other facets of medicine, orthopedics, neurology, cardiorespiratory, and that's what we do, rehabilitation. So when it comes to looking at penile rehabilitation, it's any drug or device that helps to maximise erectile function recovery. And importantly, the penile rehabilitation is subtly different to erectile dysfunction recovery. When you're trying to rehabilitate erectile dysfunction without the nerve involvement, it's about trying to get an erection that's firm enough to have intercourse. Whereas with penile rehabilitation, it's about addressing the loss of those erections that I showed you before, and helping to prevent or interrupt that process of change in the penile tissue that can become permanent. So essentially what we're trying to do, rather than just treating erectile dysfunction, is looking at a goal of trying to facilitate a recovery of the whole erectile mechanism. Now, there are plenty of options, and I'm sure that you're all very well aware of them. As a physiotherapist, my role and my scope of practice doesn't extend to some of them, so I'm going to stick with where I do, and that is the VED, which is the vacuum erection device. And it's essentially a rehabilitation aid, a little bit like what you might use after you've had a knee replacement and you need crutches. The other thing, and I'm only just going to briefly touch on it, there's something quite new, and it's vibration. There's research that's coming in that's saying that vibration can be very, very useful to achieve erection and have that maintenance. Vibration has been used in spinal cord patients for some time. And has been very, very successful, and particularly for climax for those men so that they can have children. So it's now being adapted, and there's some good research behind it. The things that you may choose with penile rehabilitation are really down to, your preferences, your discussions with your healthcare providers, what the options are for you, and it's also going to be based on things like age. We know that as you age, your erectile function is going to decrease. Something like 40% of 40-year-olds have erectile dysfunction, 50% of 50-year-olds, 60% of 60-year-olds, etc. So if you've already having trouble before you undergo some of this treatment, it really may have an impact on what you're offered on the other side. Also, your physical well-being and fitness will come into it. What are the comorbidities and health complaints you have? They're really big factors in it. And also as a couple, it depends on what your goal is. There's a lot of women that get to menopause who find sex very uncomfortable, and so as a couple you may choose not to go down that route. But there are certainly some options. So the VED, which I have left mine at home, I hope you've all seen Sharon's little things on her table out there. Sharon is a colleague of mine, if you've met her over the weekend. She is actually the president of our special interest group, and she had the pumps on her table. I left mine at home because I needed to have 7 kgs to get here, so it got ditched. And when I went through Wellington and went through the x-ray machine, I was really grateful that I hadn't brought it and had to explain what it was. But I have one to show my patients because they're interested. They want to know what their options are. And, I'm only a small part of that team, but it is a rehabilitation aid, and that's kind of what it's about. Most of you, well, I don't know, most of you, if anybody has seen any of the Austin Powers movies, he came out with his Swedish-made penis enlarger, which is actually a VED, or a vacuum erection device. And while I'm sure the enlargement factor would be considered a benefit by many men, in the case of using a VED or a pump following any of these treatments, it's more about helping to maintain healthy blood flow and flexibility of the tissue and preventing that shrinkage rather than making it larger. It's the second most commonly used rehabilitation aid worldwide, second to the medications. And when appropriate, it can be used following any form of nerve-sparing or non-nerve-sparing prostatectomy, because you do not need a nerve. So you can still keep that hope alive. Now, what we know is that in a lot of cases, if you're told you have a non-nerve sparing, it really does mean that. But there are still some cases that over a 2-year or 3-year period, there are some changes and some of that spontaneous erectile function can recur. So it can be useful. The other thing about the pumps is they can be used with a ring from quite early on if anybody's interested in maintaining a sexual relationship and they don't want to look at things like the injections. That's also an option. And you really can consider using a VED or a pump a little bit like taking your penis to the gym and doing a workout. It's just maintaining the tissue and maintaining the hope that will recover. So it's a little bit like a just-in-case policy rather than a wait and see. In terms of what the literature is suggesting, the literature is suggesting lots of things, but nobody is agreeing, all right? What is commonly kind of discussed is that the medication and the pump together seem to be a really good first line for those that can take the medication. In terms of the pumps, there are a couple of contraindications. So if you have a bleeding disorder or you're taking any form of anticoagulant, then you can't use it. The other thing is that anybody that has priapism, which is a history of prolonged erections that won't go down, then you can't use a pump. But in combination with medication, it looks like there is some really good research to support it. The other options are a progression. Now, this slide with the progression is taken from the reading that I've done, and although I say there's no consensus, there seems to be a little bit of a shift where let's start with this that might be quite useful, then we can try this. But it is a consultation, all right? It's a consultation process with partners and with your healthcare providers. And it's also really important to acknowledge, where you are on your journey and whether you want this to be something that you'd like to maintain or not. And it's also not everything is appropriate for every person. So just to finish off, life-saving treatments often have life-altering impact. We do have an opportunity to challenge the current landscape. Physiotherapy is not involved a lot here in New Zealand, and there are lots of reasons for that, including the cost-benefit ratio, and a lot of the pelvic health physios actually work in the private sector, although, as I say, there are physios in most hospitals throughout New Zealand. But I think it also comes down to a choice, and I think that at times we presume things about our patients and about affordability, and that they can't afford to or they wouldn't choose to go. But given choices, often people will make some of those decisions for themselves and choose to forego other things. So basically, I'd quite like to promote the idea of individualised prehabilitation, which is before the surgery. We know that in women, at least 40% of women that are given a handout on pelvic floor exercises do it wrong. So it makes me wonder, when women have had so much education on pelvic floor right from when they've had babies, how men cope. And, I do see that clinically. Some of them find it quite hard. And it's about optimising potential outcomes so that we decrease the dissatisfaction. And penile rehabilitation for those, as I say, who would like to continue to be sexually active where possible. It's proactive. It gives them something to do to keep that hope alive. And it helps to improve treatment satisfaction for all. And just the last slide is that I am very fortunate to have been supported by colleagues internationally because, as I said before, there is a real growth in physiotherapy involvement in men's health, and we're kind of on the beginning of seeing some changes and starting to promote men's health as a special interest group and what we can offer.